So we're going to talk about more about HIV. We're going to talk this time about interventions, which I think is an important piece to HIV. And I'm going to move this a little bit. Yeah. Good. Yeah, that's better. Okay, so pillars of prevention for HIV are combination prevention for adolescent girls, young women, and their male partners in high prevalence locations. Combine prevention with key populations, comprehensive condom programs, voluntary medical male circumcision, rapid introduction of pre-exposure prophylaxis, or PrEP for short. So when we approach HIV, we're taking a multi-pronged approach. We have to talk about behavior. We also have to talk about realistically getting people used condoms when they do have sex, and also the possibility of specific medical interventions to mitigate transmission. So no new HIV infections, and this is a sort of diagram of the sort of multi-pronged approach that organizations are taking regarding to HIV. Increased knowledge of HIV status. Obviously, the first thing we want people to do is know their status so they can react and change behavior if they need to. Prevent new HIV infections so that people do not transmit. Reduce transmission of HIV through either condoms or prophylaxis or behavior change, and rapidly detect and interrupt active HIV transmission. This would be more of a medical intervention, or condoms in that sense. So lots of different ways of approaching this. It's very complex to get HIV transmission down. Barrier methods, health programs, the standard and obvious things. Target young girls. Instruct them of their risks, so they have adequate information to be able to make decisions for themselves about whether to have sex with certain partners or know about condoms. Where female empowerment is definitely a major prong in this approach to HIV. Also, making things like condoms available is important. Having sexual resources out there that people can access freely and whenever they need it. Targeted surveillance, relative risk of HIV acquisition by population group compared to the general population. So female sex workers, IDUs, injected drug users, gay men, and other men who have sex with men. And transgender women. Know your populations. Yes. Key risk populations, new infections 2017. Regionally, HIV prevalence is different. So the distribution of the different populations is different in different regions, and this obviously informs how local areas approach public health interventions and public health prevention campaigns. I'm not going to go through these. Find hotspots is important. Find where the transmission is actually occurring, target that, and hopefully mitigate transmission spread of the disease to neighboring areas. A lot of HIV transmission sometimes relies on transportation networks, so targeting things like truck drivers and the places they stop for your intervention campaigns can help be effective and prevent spread. HIV burden in sex workers in East and South Africa, it's all over the place. Some countries are worse than others, for sure. Some countries are better at surveillance than other countries, like Angola here. I'm sort of skeptical of this number, I don't know. But in general, what you find is that some of the countries that are economically doing a little bit better have higher HIV prevalence than others, and prevalence can be concentrated in higher echelon male populations than poor male populations. It's really all over the place. But there's really some sort of counterintuitive things going on with HIV transmission in sub-Saharan Africa. It's like South Africa is up there, for example. We would assume that being it's a country that's one of the richest countries in sub-Saharan Africa, that maybe it would have a lower prevalence of HIV, but this is actually not the case. Botswana and South Africa are very high. Malawi, of course, is very poor. Heart. First generation antiretroviral therapy, ARTs, HART stands for highly active ART. Drug resistance to AZT emerged quickly in the 1990s. AZT was an early drug for HIV that Anthony Fauci was actually one of the proponents of at that time. The cycling of multiple drugs was needed. Newest regimens include at least 3 drugs, nucleoside, nucleotide reverse transcriptase inhibitors, NNTRIs, protease inhibitors, and integrase inhibitors. Easy to use, fixed dose pills are now the norm to reduce sort of the level of thinking that the patients have to do. Just get one pill, you go pick up your pills and they give it to you and you take them every day. Impact treatment is prevention, because when you treat HIV, you reduce viral loads and thus reduce the likelihood of people transmitting. PrEP, pre-exposure prophylaxis. This is a drug that people take to prevent transmission of HIV. CDC PrEP for sexually active men who have sex with men, heterosexually active women and men with high risk, transgender women and men, serodiscordant couples, impacts men, transgender women who have sex with men. PrEP reduced risk by 90% in those with high adherence. In heterosexual HIV discordant couples, PrEP was 75 to 90% effective at reducing HIV transmission. If your partner is HIV positive, obviously you want to prevent transmission to the non-infected partner. Voluntary medical male circumcision. So in many countries, circumcision in infancy is not the norm. And so encouraging men to be circumcised in adulthood is helpful, because it's known that circumcision can reduce the probability of transmission, the efficiency of transmission from men to women. Ecological studies in the 1990s suggested male circumcision rates impacted transmission. Biological plausibility. Trials suggested by MFC reduced female to male risk by 60%. A one-time cost, no adherence issues, some implementation challenges. Prevention of mother-to-child transmission of HIV. HIV transmits vertically from mothers to infants. Infections possible during pregnancy, labor, or breastfeeding. Most infections are believed to occur during delivery itself. High viral load is a major factor. Mother gets ART throughout pregnancy. Infant gets 6 to 10 week course of AZT monotherapy as soon as possible. Cesarean is preferred at high viral loads. I'm not going to go through this. Combined harm reduction and test and treat. So harm reduction is recognizing that a problem exists and sort of reducing the worst effects of it. Number of people who inject drugs who are diagnosed with HIV receiving care and achieving viral suppression in Helsinki, Finland. So we're providing medication to people who are using injectable drugs. We accept that they're using those drugs and just want to reduce the harm of it. Obviously, public health professionals are probably offering things like treatment services to people who are using injectable drugs. But the idea is that we want to recognize there's a problem and recognize that people are going to do it, whether we tell them to or not, and mitigate their risk for other conditions. Okay, that's it. That's all I want to talk about there. HIV prevention, public health intervention methods are many, but many of them are effective, and they've been responsible for reducing HIV transmission overall. So, I'm going to move on to barriers.